Hello, Dr. Arvind.
Hi, good evening, ma'am.
बाकी कोणी झालंय की नाही?
हो ना, स्पीकर काही आले नाहीत अजून.
10 पार्टिसिपंट दिसतात आहेत.
पाटणकर दिसतोय, पण त्याचा नुसता फोटोच दिसतोय.
अमोल आहे, ज्येष्ठराज आहे, तुम्ही आहात, मी आहे. ओके.
हो.
तुम्ही 2 ह्याच्यावरनं आहात का? अनुज आणखीन अरविंद?
झूमवर त्याचं नाव आहे, त्याच्यामुळे ते आला असेल बहुतेक, मला असं वाटतं.
ओके ओके.
हाय हाय.
अजून फार कोणी आलेलं नाहीये.
हो, सेक्रेटरी आले नाहीत अजून.
हो, सेक्रेटरी मॅडम आलेली. ज्येष्ठराज आहे का तू?
हाय अमोल.
Yes, madam, I'm there.
हाय
ओके.
राज.
Hello, sir.
हाय हाय.
जिनेका मधनं भरत आहे का?
काय मॅडम, एक मिनिट, थोडा साऊंड वाढवतोय मी.
जिनेका मधनं भरत आहे का?
हो मॅडम, आहे, मी आहे.
ओके ओके. आत्तापासून रेकॉर्डिंग करू नका प्लीज. आपण सेशन चालू केल्यावर रेकॉर्डिंग ऑन करा. आणि को होस्ट म्हणून मी सुजाता. नाही, हे चालू करून
आली नाही वाटतं.
केलंय मॅडम, तुम्हाला को होस्ट केलंय आणि
हो.
बाकी जे मॉडरेटर्स आहेत त्यांनाही केलंय आणि प्रेझेंटर्सला पण केलंय.
हा, राईट राईट राईट. थँक्यू. आणि आम्ही तेव्हा एकेकाला इंट्रोड्यूस करू तेव्हा बुके दाखवाल.
येस येस.
सुजाताचा फोन आहे.
अरविंद सर, स्क्रीन दिसते का माझी?
येस येस येस.
दिसते ना?
हो, दिसते दिसते.
ओके, मी स्लाइड शो करतो. कधी
ओके ओके ओके.
कधी स्लाइड शोला प्रॉब्लेम येतो.
हा, व्यवस्थित दिसतो.
दिसते ना? प्रमोद सर, गुड इव्हनिंग.
गुड इव्हनिंग ऑल.
गुड इव्हनिंग सर.
गुड इव्हनिंग.
गुड इव्हनिंग.
Please move this window away from the share. मला वाटतं ते लाईव्ह स्ट्रीमिंग मध्ये शेअरिंग दिसत नाही वाटतं व्यवस्थित. हायलाइट होत नाही ते जोपर्यंत चालू करत नाही तोपर्यंत.
स्लाइड दिसतायत ना?
दिसतायत का?
हो.
पण स्लाइड शोला आता ते दिसत नव्हतं ना व्यवस्थित वाटतं.
आता केलंय, आता नाही दिसत.
मी एकदा चेक करतो स्लाइड शो.
हो, आल्या ना स्लाइड.
नाही, स्लाइड शो कर. स्लाइड शो कर.
देखो, मेसेजेस दाखवला डायरेक्ट.
हो, तो ISI ह्युमर माझा व्हॉट्सअप उघडलं तर त्याच्यात आहेच ना, होतं आधी कनेक्टेड. हॅलो.
हाय.
आता किती आहेत पार्टिसिपंट? सुरेखा चव्हाण
सध्या आता 38 आहेत.
बालाजी आलाय.
गुड इव्हनिंग मॅडम. गुड इव्हनिंग. गुड इव्हनिंग.
आणि ते
काय
दिसतोय
म्हणता?
कार मध्ये घरी
हा,
पोहोचत.
गाडीत आहे. हो. काय म्हणता?
बस आता तो ऐक.
काय?
ऐक.
हो, ऐकण्यात फार मजा आहे.
हो, ते खूप असतात.
बालाजी सर गुड इव्हनिंग.
काय म्हणता?
गुड इव्हनिंग सर.
गुड इव्हनिंग. गुड इव्हनिंग. जस्ट राज. बेस्ट ऑफ लक दोघांना.
येस सर, थँक्यू.
हो, थँक्यू सर.
सर स्लाइड दिसते तुमची.
नाही, ते मी स्लाइड शो जेव्हा करतोय ना तेव्हा ते काहीतरी मेसेज येते, मी तुम्हाला दाखवतो. युअर स्क्रीन शेअरिंग इज पॉज्ड म्हणून येते. असं ग्लो चांगला आहे का स्क्रीनचा?
हो, दिसतंय आम्हाला. दिसतंय
व्यवस्थित दिसतंय.
एकदम क्लिअर आहे का?
हो.
अच्छा,
क्लिअर आहे.
त्याचा ब्राईटनेस आपोआपच कमी जास्त होतोय.
फॅनचं स्पीड कमी कर.
चांगला आहे, काही प्रॉब्लेम.
अरे पण मला दिसत नाही इकडे.
हॅलो, गुड इव्हनिंग.
गुड इव्हनिंग.
गुड इव्हनिंग मॅडम.
गुड इव्हनिंग. गुड इव्हनिंग. सॉरी मीच उशिरा
आले का? हॅलो.
हॅलो. हा सर.
सेक्रेटरी उशिरा आले का म्हटलं?
होस्टच उशिरा आहेत का? येस येस. ते माझ्या संचितच्या टॅब मधला झूम निघाला, त्याच्यामुळे ते प्ले स्टोर वरनं डाउनलोड करायला वेळ लागला. मग ते आता दुसऱ्या मोबाईल वरनं लॉग इन केलं.
ओके. मी अनुजच्या मोबाईलवर लॉक केलाय.
हो का?
नाव येते त्याच्यावर.
करेक्ट. हा.
खरंच सुरू मला असं वाटतं.
करायचं सुरू.
करूयात. 7 वाजले.
हो.
एक्झॅक्टली.
5 मिनिटं अजून. मला वाटतं स्नेहा वगैरे जॉईन नाही झाली, तर 1-2 मिनिटं वाट बघेल.
ओके.
फोन करते तिला मी.
ठीक आहे.
आणि देशपांडे सर पण नाही आले. प्रसाद देशपांडे सर.
प्रसाद देशपांडे सर जॉईन झालं वाटतं ना.
दिसत नाहीये प्रसाद.
प्रसादचं
हा,
नाव
आय 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 आले आले आले.
प्रसाद आहेस का?
नाव तर दिसतंय प्रसादचं.
हॅलो.
हा,
सरांचं
प्रसाद.
आहे आवाज आला प्रसादचा.
हो ते काय मला सवय नाही थांबा जरा. हॅलो.
दिसला
हा,
आता मी सुशील म्हणूनच आहे. यू अंडरस्टँड आहे मीच आहे पण. प्रमोद आहेस ना? तुझा व्हिडिओ ऑफ आहे प्रमोद.
हो मॅडम, मी आहे मॅडम.
हो हो ऑन ठेव तुझा.
हो हो. दुसरीकडे बसू.
सुजाता म्यूट केलंय. तिला फोन करूनच सांगितलंय. अमोल आणखी जेस्टराज तुमच्या स्लाइड रन होतात आहेत ना? टेस्ट केलं का?
होत आहेत मॅडम.
मला ऍक्च्युली थोडेसे हेल्प लागणार आहे. ते आता जे
स्क्रीन
वाटल्यास मला पाठवून मी शेअर करतो तुझे.
इश्यू काय होते माहितीये का, मी जर स्लाइड शेअरिंगचं मी स्लाइड शो जेव्हा मी ऑन करतोय ना तेव्हा ते तुम्हाला दिसतंय पण माझ्याकडनं पूर्ण ब्लॅकआउट होऊन जाते. ब्राईटनेस कमी जास्त होते. आय डोंट नो काय इश्यू.
तुमच्याकडे 2 स्क्रीन लावलेले आहेत का वेगवेगळे?
2 स्क्रीन नाही सर, एकच आहे फक्त. म्हणजे तुम्ही हे म्हणताय का, विंडो म्हणताय का?
हा म्हणजे नाही तुम्ही तुमच्या पीसीला 2 स्क्रीन लावलेले आहेत का? 2 स्क्रीन वापरता?
अरविंद राजगुरे
नाही.
सरांची.
मग एक काम करा ना सर, ती एक तर मला पाठवा प्रेझेंटेशन किंवा मग ते दुसरे तुमचे कलिग आहेत त्यांना पाठवता का? तिथून शेअर करा मग.
तिकडे शेअर करू का मी?
हा
एकदा लास्ट ट्राय करतो, नाही तर मग
हा करा. शेअर स्क्रीन मध्ये जा आणि पूर्ण डेस्कटॉप शेअर करा सर.
एक मिनिट, तुम्ही सांगाल तसं करतो मी. एक मिनिट.
हा शेअर स्क्रीन मध्ये जा.
मी आता शेअर स्क्रीन मध्ये गेलो. हो.
आणि पूर्ण डेस्कटॉपला सिलेक्ट करा.
आता माझ्याकडे स्क्रीन, व्हाईट बोर्ड, आयफोन, आयपॅड, मायक्रोसॉफ्ट पॉवर पॉइंट आणि सिट्रिक्स वर्कप्लेस एवढं आलंय शेअर करण्यासाठी.
स्क्रीन करा.
स्क्रीन करू
आणि शेअर करा.
येस, नाऊ आय हॅव शेअर्ड. आता मला हे दिसते वाटतं तुम्हाला?
हो दिसतंय आम्हाला पूर्ण.
बरं, मी आता फक्त स्लाइड शो करतो.
हा करा स्लाइड शो. दिसतंय.
येस, मला पण विजिबल आहे. मला फक्त ट्राय करतो. हा ठीक आहे, नाव इट्स फाईन.
ओके डन.
थँक्यू.
ओके थँक्यू.
जमलं म्हणजे.
जमलं. हो मॅडम. एक छोट्या गोष्टी माहित
नाही करता जमतात.
एक्सपर्ट टेक्निकल हेल्प आवश्यक असते कधी कधी.
प्रत्येकाची एक्सपर्टनेस.
एक्झॅक्टली. सुजाता चालू करायचं का?
हो, ही दिसते का? स्नेहा आली का?
स्नेहा आली का?
कारण मग ते ऍक्च्युली इंट्रोडक्शन पार्ट त्यांना दिला होता ना, त्याच्यामुळे मला असं वाटलं की.
पण आली का ती स्नेहा?
नाही दिसत तर नाहीये.
नो वन नीड्स इंट्रोडक्शन हिअर.
म्हणजे आज आपल्या प्रेसिडेंट सेक्रेटरी ग्रुपवर झालं तसंच आहे का? फक्त
खरंच आहे.
मॉडरेटर, प्रेसिडेंट सेक्रेटरी
आणि स्पीकर एवढेच जण.
नाही ऍक्च्युली that shows the resistance towards pain.
नाही
It is fact actually.
रेझिस्टन्स नाही. हे बघ अमोल, आजच आमच्या प्रेसिडेंट सेक्रेटरी ग्रुप वरती हे डिस्कस झालं that the same situation is with all the city branches.
Agree madam.
आणि दुसरी एक गोष्ट आता कशी झालीये का आफ्टर कोविड दिस इज द फर्स्ट वेकेशन, त्यामुळे बरेच जण आउट ऑफ स्टेशन आहेत.
हो आहेत, बरोबर.
आणि लोक इतकं एन्जॉय करतात ना सोशलायझिंग, का मग त्यांना असं वाटतं का आता नको अकॅडमिक.
बरोबर आहे, खरंय मॅडम, ते पण आहे, बरोबर.
सगळ्यांचं ओव्हरऑल मत ठरलं.
नाही ऍक्च्युली सुजाता मॅडम म्हणाल्या होत्या की ऑफलाईन करायचं चाललंय म्हणजे.
हो, तेच ऍक्च्युली बघत होते, पण मग हे बाकी अवेलेबिलिटीच कोणाची नाही दिसली, म्हणून मग म्हटलं आता शेवटी मग आपण ह्याच्यावरती झालो. म्हटलं ऍटलीस्ट मंथ स्किप नको व्हायला, समथिंग हॅज टू बी डन. आणि म्हणून मग आपण तसं
जूनची आपण नक्की ऑफलाईन घेऊया आणि ती कॅज्युअल मीट राहील असं मला वाटतंय. आपण करूयात एक कॅज्युअल मीटिंगच सगळ्यांची, सो दॅट एव्हरीवन इज मोटिवेटेड टू जस्ट चिट चॅट विथ इच अदर अँड गेट टू नो इच अदर.
आणि वी विल जस्ट म्हणजे लेट अदर्स नो व्हॉट AA इज डुईंग, व्हॉट ISA ऍक्टिव्हिटीज आर डुईंग, व्हाय इट इज नेसेसरी टू गो फॉर द मेंबरशिप अँड ऑल दोज थिंग्स. त्याच्यामुळे थोडस तो अग्रेसिव्हनेस थोडा लागणार आहे आपल्याला.
कारण मागच्या कोविडच्या ह्याच्यात 2 वर्षात आपण काहीच झालं नाही, फक्त ऑनलाईनच भेटतोय. त्यामुळे आता ऑफलाईन भेटून परत आपल्या भेटीगाठी सुरू करणे जरुरी आहे.
हो.
पण आणि हा कसा मे महिना आहे, सॅटरडे आहे, लोक जराशी रिलॅक्स असतात सॅटरडे
वीकेंड आहे, बरोबर.
सध्या तर MR लोक बरेच मागे लागलेत मॅडम, ऍक्टिव्हिटी घ्या, स्पॉन्सर घेऊन टाका मग काय.
हा, चालू करायचं ना. नाही एक आता मीटिंग घेऊया जून मध्ये. जूनची मीटिंग आपण GPM टाईपच ठेवूया, बरं का बालाजी?
बरं.
आणि जस्ट आपली ऍक्टिव्हिटी आणि वी विल कॉल स्पेशली कॉल ऑल न्यू कमर्स सो दॅट वी गेट टू नो टू.
बरं.
आणि सगळ्यांचं मत काय रेट लिस्टचं?
हो, नाही करायचंय मॅडम रिवाइज.
हा, मग तो एक मुद्दा ठेव म्हणजे
पोस्ट करू ना, एवढे रेट्स वाढलेत.
सर्जनचं पण आलंय रेट लिस्ट, ऐकलं का त्याबद्दल?
हो का?
हो.
नाही
त्यांचं GBM मध्ये झालंय सँक्शन.
बरं. अच्छा, मग आपण आतापासून मेसेज टाका आणि करूयात ते.
जूनला मला वाटतं ती एक तशी मीटिंग घेतली आणि GBM तर लोक येतील.
हो. नाही, आता आपलं असं ड्यू होते मध्ये, मागच्याच एप्रिलमध्ये मला वाटतं.
एक्झॅक्टली, आय नो.
आवश्यक आहे आता आपल्याला चेंज करणं.
तर आता आपण नेक्स्ट जूनची तर डेफिनेटली ती करायची. मी सुजाता बोललो पण आहोत, आपण जूनची ती करूया.
I think we can start now. It's already 7:10.
Ali, Sneha, Ali?
Yeah. Okay.
Yes, please.
Very good evening to everyone. So we all are meeting after great success of ISA national sponsored CME after about a month. Today's session is exclusively on the most upgrading topic and the branch pain management. For today's session, we have expertise and moderators from very renowned and very practicing pain physician from our own city. Also, our today's speaker are very young and dynamic pain physician doing dedicated work. As you all know, since 2020, we renamed our association as Association of Anesthesiologists Aurangabad. And our trust has been formed and we are working under this trust. Now, our account is also been shifted to the central bank. Details are already circulated in our group. We expect and request all the young and budding anesthesiologists to join the association and get the benefit of AAA platform. Today, I am very happy to announce that our city is in ready position for one more association, that is Aurangabad Pain Society in the recent future. And for this, Dr. Arvind Rajgure sir, who is our moderator for today, is the first president to be for this Aurangabad Pain Association Society. So our today's exclusive session is for pain management beyond nerve block. I request Dr. Sangeeta Madam to please extend warm welcome. Dr. Sangeeta Madam.
Thank you, Sujata.
Hello.
Ha, Sangeeta Madam.
Yes. Good evening, friends. I, President of Association of Anesthesiologists, Aurangabad, welcome you all for the topic Pain Medicine Beyond Nerve Block. Gradually, our anesthesia branch is spreading like an octopus to various different branches like labor analgesia, pediatric anesthesia, neuroanesthesia, cardiac anesthesia, TIVA, regional blocks, segmental spinal blocks, geriatric, and many more. In that, pain clinic is also a very budding new branch. We, Team AAA, have two young dynamic pain medicine beyond nerve block speakers, Dr. Jeshtaraj and Dr. Amul Panda. Moderators are our own senior pain medicine physicians, Dr. Arvind Rajgure, who will be the first president of Pain Association, Dr. Pramod Apsingekar and Dr. Prasad Deshpande. I will not take your much time. Thus, I request our Joint Secretary, Shri Gopal Bhattat, to introduce our first moderator, Dr. Arvind Rajgure.
Sir has not joined, so
okay.
I don't see him. He has joined. So please kindly you introduce the Dr. Rajgure, sir.
Just a minute.
Mr. Bharat, can you please share the slide of Dr. Rajgure, sir? Yeah, yes.
Yeah, Dr. Arvind Rajgure, he has done MBBS, MD, and Fellow in International Pain Management in 2009 at Dardia Pain Management Center, Calcutta. PGCC Rheumatology in 2014 at AK Sinha Institute, Patna, Bihar. Senior anesthesiologist and pain management consultant at Aurangabad. Professor at JIU Medical College and Hospital, Badnapur. Running an advanced pain management center at Aurangabad since 2013, published various research articles in various journals of special interest, renowned Journal of Anesthesia and Analgesia on radiofrequency, Gasserian ganglion in patients suffering from trigeminal neuralgia, had successfully treated around 175 cases of trigeminal neuralgia over years. Then research article on radiofrequency ablation of genicular nerve joint in chronic knee joint osteoarthritis patients.
Thank you, ma'am.
We welcome you, sir. Arvind Rajgure, sir.
Thank you very much. Thank you.
Yeah.
Bharat, bouquet de na. Floral bouquet.
So please accept this virtual bouquet this time, and in the next meet we will give you the actual bouquet.
Yes.
So now I request Dr. Sneha to please introduce our next moderator, Dr. Pramod Apsingekar, sir.
Hello.
Yes.
Am I audible, ma'am? Am I audible?
Yes.
Good evening, all. Dr. Pramod Apsingekar, sir. He is a consultant cardiac anesthesiologist and pain physician. He is the director of Ozone Anesthesia and Critical Care Private Limited. Sir has numerous firsts to his credit. First one to do the awake bypass surgery in 2011. First in Marathwada to get fellowship in pain management from Delhi Pain Management Center. He was also involved in the team of first heart and liver transplant of Marathwada. I welcome Apsingekar, sir. Thank you.
Now I welcome Dr. Prasad Deshpande, sir. Am I audible?
Yes.
Yeah. Now I welcome Dr. Prasad Deshpande, sir. Sir is again a pain physician, and sir has completed. Sir is a student from Government Medical College. Sir has secured gold medal at in MD examination. Sir has worked as clinical assistant in PD Hinduja Hospital for 1 year in Department of Critical Care and Department of Anesthesia. Sir has also worked as consultant anesthesiologist since 2003 with a special interest in the field of pain management and pediatric anesthesia. Sir has completed pain fellowship at Delhi in May 2012. Presently, sir is working as a consultant interventional pain physician and anesthesiologist at Aurangabad. Sir was invited as faculty at CME on pain management by IMA Aurangabad, CME on pain management by IMA Jalna, and by ISA Aurangabad. Sir has conducted ANACON 2015. Sir was secretary of ISA in the past. Sir had worked as organizing secretary for ANACON 2014. Also joint secretary for the grand and in the grand venture of MISACON 2016. And sir was governing council member for Maharashtra State Chapter. We Team Association of Anesthesiologists welcome you, sir. Dr. Prasad, sir.
Hello. Thank you, Sujata.
Yes, sir. Even I have worked with sir as during the organizing committee. It was so nice to work with you. Yes, may I request Dr. Sangeeta Madam to please introduce Dr. Jeshtraj, our today's speaker?
Yes. Dr. Jeshtraj, his present designation is Assistant Professor and Interventional Pain Physician. At present, he is at Pain Panacea Super Specialty Pain Clinic at MGM Medical College, Aurangabad. His major achievements are he has done MBBS in Government Medical College, Aurangabad, MD in Government Medical College, Meerut. He has done fellowship in pain medicine at Dardia Pain Hospital, Calcutta. Experience 6 years as an assistant professor, faculty for fellowship courses at Dardia Pain Hospital, Calcutta. Faculty and delivered talk on plantar fasciitis at International Conference of Recent Advances in Pain. Faculty at 36th National Conference of Pain Management in 2022. Multiple publication in international journals, multiple paper presentation in state and national conferences, attended multiple regional anesthesia and pain workshops. His special interest is in minimal invasive pain and spine interventions, cancer pain, and headache management. At Pain Panacea Super Specialty Pain Clinic, which he runs, he has a dedicated pain management experts with well-advanced, well-equipped OT, C-arm, ultrasound, ablation, advanced physiotherapy and psychological therapy center. I welcome Dr. Jeshtraj Patangdankar for a talk. Please.
Thank you very much, madam.
Welcome, Dr. Jeshtraj.
Thank you very much, madam.
Now I introduce Dr. Amul Panda. Amul Panda is a pain management consultant and running a Pain Panacea Super Specialty Pain Clinic in Aurangabad. He is an assistant professor, Department of Anesthesiology, MGM Medical College and Hospital, Aurangabad. Dr. Amul has done fellowship in interventional pain management, and in 2020, he was a faculty at IPSACON 34th Annual National Conference of Indian Society for the Study of Pain, Bhubaneswar. He received Best Faculty Presentation Award at International Conference of Recent Advances in Pain in 2021. He is a visiting faculty at Daradya Pain Foundation, Kolkata. Faculty for ISACON Maharashtra 2021 Nagpur. Award for Best Faculty Presentation in Mahayuva ISACON by ISA Maharashtra. He had received award of Excellence in Anesthesiology by ISA City Branch Pune. Spruti Trophy for work in clinical research by IMA Pune in 2015. He had also been he had various publications of national and international journals. He's a life member for Indian Society of Study in Pain. Welcome, Dr. Amul Panda. We are very pleased to have you all.
Thank you, madam. Thank you for the kind introduction.
Now I request Dr. Amul Panda to start your talk, please.
We'll start with today's proceedings. I share my screen.
Yes, go to the share screen and share complete screen.
Yes, sir. Am I audible?
Yes, audible. Your screen is visible as well.
Okay, thank you.
Yes. Put into the presentation mode. Yes, visible.
Okay, is it fine?
Yes.
Okay.
Okay. So we good evening, everyone. First of all, I would like to thank ISA City Branch Aurangabad, President Dr. Sangeeta Deshpande Madam, Secretary Dr. Sujata Dine Madam, and all the rest of the office bearers, especially for taking interest in this field of chronic pain management and also giving us opportunity to share whatever little knowledge or whatever little experience we had during after entering into this very vast field called as chronic pain management, or more appropriately, pain medicine. First of all, let me clear that chronic pain management and pain medicine, these two words will be used synonymously, and whenever there is a word called pain or pain management, it is considered with chronic pain, particularly chronic pain. So we'll start with today's session. For the sake of presentation, we have divided into two parts. First part is I will be talking around what is the present conception or what is the present scenario of handling these patients of chronic pain management around in society around us, and in the second part of presentation, what exactly is supposed to be done in chronic pain management, that will be discussed in the second part. So I will start with what what exactly mean by chronic pain management. So the pain medicine or pain management is nothing but an iceberg. Whatever little we know is just a tip, and we all know that reverse side of this iceberg is a scope, is an opportunity. So whatever participation or whatever contribution we'll be getting while handling these patients or in this field is valuable, and much contribution is needed by all of us. In our field, we routinely say that patients are our teachers. Our patients are our best teachers. So their patient's journey of suffering from a particular disease, it will teach us a lot of things. And particularly in chronic pain, this journey, many a times it may be endless because diagnosis will not be there, and most probably the definitive management, unfortunately, will not also be there. So while handling such patients, I would like to start my talk by sharing three of our patients whose journey made us introspect to think ourselves that what exactly is happening with these patients who are suffering from chronic pain. I will start with the first patient.
Yes, your slide has moved,
yes,
sir.
I will start with the first patient. She was a 59-year-old female lady. She was former patient. She was having low back pain since 2 years, for which she was getting treated with simple oral analgesics. Yes, pain relief was there, but it was still she is consuming the medication, and borderline back pain was still there. She was having only back pain without any complaint, and she was wandering from here and there. She was going to all the practitioners, but the pain was still there. She was having this pain for particularly 2 to 3 years. Then came the most commonly done or most famous investigation for back pain, that is MRI. Let us see what was her MRI. This was a picture in her MRI. She was not having diagnosis for 2 years. Now we have her MRI. Now, can we diagnose this patient? Yes, of course we can diagnose this patient. What is the diagnosis? As we all can see, there is a listhesis at the level of L5S1. Okay, the L5 over S1. The diagnosis is clear. She is having, more appropriately, she is having grade 2 spondylolisthesis. Okay, now the patient is having back pain since 2 years, for which she is consuming medication, and her diagnosis is grade 2 spondylolisthesis. But is it really causing a pain? Because most of the times, grade 1 or for that matter, grade 2 listhesis may go asymptomatic, or there will be very few mild symptoms for which surgery is very rarely advised. So what is to be done? Patient is having pain since 3 years, and her MRI is having spondylolisthesis grade 2. Where the patient should go? Who is supposed to treat this patient? Fortunately, this patient came to us. On examination, what we had found is that lady was having a tenderness in a paramedian region on the right side at L3, L4 level. Okay, there was a paramedian tenderness on the right side at L3, L4 level, which was clinically suggestive of facet arthropathy, for which she was subject to a diagnostic intervention And surprisingly, there was a 90% pain relief, means this diagnostic intervention was positive. So her diagnosis clinically was facet arthropathy. Now the MRI diagnosis is spondylolisthesis, but the clinical diagnosis, which was supported by diagnostic intervention, was facet arthropathy. So subsequently, that lady was treated for facet joint arthritis, and now that lady is pain-free. So my question to everyone is, if the pain physician or pain management expert is not available, then whom should this lady should consult? Whether she should go? What was the point which was missing in this slide? In this case was the MRI diagnosis. Yes, it was spondylolisthesis, but was it really a pain generator? Was that particular finding was causing pain to the lady? Who will give thought to this? By the way, this was the prescription which was received to the patient. It was from a very big hospital in our own city. She was consuming aceclofenac PD for 40 days, means almost 80 tablets in 1.5 months. And the worst part is, she took this medication for 3 months just by showing this description. Just imagine the dose of aceclofenac. Let's move on to second scenario. Again, there was a 55-year-old female. She was having bilateral heel pain since 6 to 8 months, which was increasing on walking, and it was released on rest. Means there was a heel pain which was increasing on walking. Then there was an occasional numbness of her feet. Okay, her diabetic status was unknown. Considering the heel pain on walking, obviously she was prescribed NSAIDs, some heel support, other measures, physiotherapy, sole support, then no relief, then some injections. The details were not available, but for 10 to 12 months, she was not having any pain relief. She has done everything, all the conservative management, the physiotherapy, injections, query injections, but no result. My thought was, what was the diagnosis? Patient was getting treated for 10 to 12 months by minimum 2 to 3 experts or specialists or a medicos. We'll label them as a medicos. What was the diagnosis? So if there was no diagnosis, it was not mentioned on any paper. Let us assume that it was a plantar fasciitis, which is a very common condition. I think Arvind sir will agree with me. It is a very common condition, and we'll assume the diagnosis as a plantar fasciitis. But there was no result because patient has received some intervention, something, but still there was no pain. Now, what should this patient should do? Again, my question, what is the diagnosis? Patient is getting treated for 12 months without a diagnosis. Is it acceptable? Let us all think, is it acceptable? Without diagnosis, patient is getting treated. Okay, were there any relevant investigations? Yes, I have an X-ray. I have done my X-ray. But X-ray was normal. The X-ray was normal. There was no calcaneal spur, or there was no any obvious trauma or fracture or anything. So now again, patient's X-ray is normal. Patient is having heel pain since 12 months. Patient has done everything. What should patient do? What next? Okay, patient should have a second opinion. Patient should consult some expert. Whom? My question is to whom? Patient has shown to all the specialists with the concerned faculties, but still there is no pain relief. What should patient do? Or for that matter, whether patient should consult an allopathic practitioner or an Ayurvedic practitioner. We will blame that, okay, patient will do other treatments, they will not stick up with the routine treatment plan. But why they are going to other practitioners? Why they are doing some non-ethical and non-medicinal treatment? Is because they need pain relief. They have come to you, but you have still not diagnosed the patient. How can you treat it? Fortunately, when this patient comes to a pain physician, that pain physician, what he did is, he did an MSK ultrasound of her heel, and surprisingly, all the findings were normal. Nothing was in her ankle. No any evidence of plantar fasciitis or any other pathologies like Achilles tendinopathy or etc. Her heel was absolutely normal. And one more particular finding on evaluation, the straight leg raising test was a positive. So SLR was positive, ultrasound examination of heel was normal. So that young, very new physician labeled it as a lumbar radicular syndrome, and simply he tried very basic medicinal conservative management only for 10 days. And surprisingly, that patient had pain relief for almost 80 to 85%. Patient responded very well, which he was not given during last 12 months. Again, my question is, if you don't have a diagnosis, how can you treat a patient for 12 months? I will go to third scenario. There was a 55-year-old medical practitioner. He was general practitioner. Now that this patient, he was referred by a spine surgeon to pain clinic for management of diabetic neuropathy. He was labeled as having diabetic neuropathy, and he was labeled as a diabetic neuropathy, and he was sent, assuming that we were to do some interventions. Okay. Now, what was the complaints? That patient was having burning pain of moderate to severe intensity in bilateral lower limb below the ankle. Means there were burning fits. Okay. And patient was having long-standing diabetes mellitus for almost 10 years. So the scenario is 55-year-old male who is having burning fits below the ankle, and he is having diabetes since 10 years. So he is having diabetic neuropathy, and sir, I am referring to you. Please do something. Please do some interventions. Now, when we have examined this patient, we had a diagnostic dilemma. Why? Because there were some findings of examination which were in favor of radicular syndrome, while some were not. Because why we thought of lumbar radicular syndrome? Because in this patient, straight leg raising test was positive. Pain was aggravating on bending, and more appropriately, the touch, vibration sense, and the deep tendon reflexes were intact. And what was in favor of diabetic neuropathy? That it was a bilateral involvement. Pain was non-radiating character. There was no tingling and numbness, and it was of long-standing diabetes. So nothing was clear. Everything, there was a complete diagnostic dilemma. So in such scenario, if you are not confirmed about diagnosis, are you supposed to do some intervention or any treatment considering or assuming that it is a diabetic neuropathy? Of course not, because you have to confirm the diagnosis. So what a pain physician can do here, or what we have done here, simply patient was having bilateral lower limb burning pain. Patient was having SLR test positive, so we advised an MRI. Now, what was the MRI has to say? This was a picture in MRI. There was a L5S1 disc disease with bilateral exiting and traversing root compression. There was a clear evidence of root compression. So what we simply did is we simply perform a diagnostic intervention to see whether the patient is having transient pain relief or not. And surprisingly, this patient was referred by a spine surgeon for a diabetic neuropathy treatment. He was having lumbar radicular syndrome. Diagnostic intervention was positive. Again, this patient beautifully responded to conservative management as well as very minimally invasive procedures. So these were the three patients or the three scenarios which I wanted to discuss. If you have a close look in these three scenarios, in the first scenario, yes, that spondylolisthesis lady, we had an MRI diagnosis of spondylolisthesis, and she was having back pain. But was it really the cause of back pain? Was it really a cause of back pain? In other language, was it really a pain generator, which is very important whenever we are practicing a pain management? The most important thing is to find a pain generator. Pain generator is a parallel word which we are using for diagnosis. Mr. will elaborate all these things in his presentation. I'll just make ourselves familiar with these terms. So we were having MRI diagnosis as anesthesis, but was it really a pain generator? No, because why? Because in diagnostic block, when we have intervention at facet level, patient had a pain relief. So patient was having the listhesis diagnosis was correct, but this correlation of back pain and listhesis was not there. So again, my question: who will do that? So here, missing link is pain physician or a pain management expert. Similarly, in second scenario, patient was getting treated for heel pain for 12 months. Means, in short, patient is having chronic pain for 12 months. Who is supposed to diagnose? Again, missing link is pain physician. And also in third scenario, the exclusive interventional modality or exclusive diagnostic modality, which is very commonly done by pain physicians, is diagnostic interventions. We all know that pain is almost, if a pain is there, almost always some sort of nerve innervation has to be there. And in simple language, if you are blocking that particular nerve, or if you are injecting local anesthetic to the particular nerve, that pain has to decrease. It will decrease. Indirectly, it will confirm the origin. So again, the diagnostic interventions, which when we are using them, it will clearly highlight the diagnosis which has been done in the third scenario. That is, we have confirmed the diagnosis as a lumbar radicular syndrome. And mind you, that patient was referred for diabetic neuropathy. So if we are not going for diagnosis, we can also land up in treating diabetic neuropathy. And that can happen. It can happen. But again, the use of diagnostic intervention is missing. In short, what is the missing link is chronic pain management. The concept of pain management and a pain physician is a missing link. Why this is happening? Why this is happening? Why patients are not able to come to a pain clinic, or why the people are not getting treated by n number of options available for their chronic pain in our allopathy? Yes, it is lack of awareness. We all will blame people that people are unaware. They don't know. They should consult a pain management expert. There are pain clinics. But is it really so? Are only the patients or the common public is not aware about pain? The lack of awareness of chronic pain as a disease is prevalent not only in general population, but also among our medical fraternity. And this was a very wonderful article which was published in Indian Journal of Pain. This was an original article. It was a study done by my senior colleague, Dr. Archana Deshpande. She is a practicing pain physician from Nagpur. She has done this study about awareness, attitude, and knowledge about pain clinics among general practitioners in Nagpur city, for which she has included almost 350 to 380 practitioners from Nagpur with varying experience from less than 5 years to more than 25 years. And two of her important results I want to fetch here and I want to highlight upon is the awareness about pain clinic in medical fraternity. It will not go hand in hand about the years of experience of practice. Means in short, the older is the practitioner, means he will be aware of pain clinic. It is not so. Even the practitioners with more than 20 years of experience, still almost 35 to 40% of practitioners were not aware about the pain clinics. But more worrisome finding was, whatever practitioners, whoever or whatever amount of practitioners, those who were aware about the pain clinics, they were resistant to referring their patients to the pain clinic. Almost 70% of the practitioners who were aware about the pain clinics, they were not referring the patients to the pain clinic. Why this is happening? Why this is happening? Is it only because of lack of awareness, or is it improper awareness? I think both are. Lack of awareness is also there and improper awareness is also there. The moment we hear chronic pain management or pain medicine or pain management, I will ask all of you, including me, what will come in our mind whenever we are thinking about pain management? What will come in our mind? Definitely, the answer is some sort of injection, intervention, neurolysis. It will be done, and the patient will be pain-free, or I will be pain-free. It is happening with everyone, because the patient or the common people, they'll perceive that pain management, it is nothing. It is just go to the clinic, get yourself injected for that particular disease, and the next day you will be pain-free. Again, on top of that, if in case some other practitioners or some other medicos or our friends, if they are referring patient to us, what they'll say, you go there, they'll put an injection, they'll put some injection, and you will be pain-free. You go there. And unfortunately, I have to say, some of our colleagues who are practicing pain management, we have a mindset that whenever a patient comes to OPD, whatever complaint he's doing, the moment he's telling complaints, we will start thinking about the interventions. What interventions I can do? This is happening. This is happening, and it will it will propagating the fallacious or misleading concept of pain management. So again, I will not blame anybody. Everybody is at fault. Everybody is at fault. The person who is getting treated, the people who are creating awareness, as well as the us who are misleading patients regarding the concept or definition of pain management. So we all have to introspect. Again, this very wrong and very misleading concept, that is, you just poke it, inject it, and forget it. This should not happen. It should be strongly condemned. Pain management is not only about poke, inject, and forget. It is a very different concept. Yes, we are going to elaborate this in our second part of presentation. Okay, let us assume that even we are agree upon a thought that chronic pain management is a very vast specialty, but still pain is almost always from a nerve. So apart from doing some neurolysis, chemical, thermal, or for that matter, immunolysis, what else we are supposed to do? What else we are supposed to do? This question will be there in everybody's mind. What else we are supposed to do? Okay, if we assume that that is the only concept, then let me tell you, who will dare to open this mysterious box that contains such terminologies called as fibromyalgia, chronic fatigue syndrome, myofascial pain syndrome, phantom limb pain, failed back surgery syndrome. These are the entities, half of them don't even have interventions. And incidences prevalence is very high. Fibromyalgia is a disease with a distinct diagnostic criteria, and there is no any single intervention, or for that matter, if I am not wrong, there is no any intervention to treat fibromyalgia. Incidence is there, prevalence is there. Then who is supposed to treat these patients? Or we are not supposed to treat? Who is supposed to treat? So if we assume that pain management is only about doing intervention, then who is going to explore this mysterious box? Who is going to dig in deep? Who is going to do research? Or who is going to come up with some diagnostic criteria? Many of the entities are not even having diagnostic criteria. Forget about treatment management. And yes, they are existing entities. I have mentioned in bracket, I have mentioned about the ICD classification and with their respective codes, just to increase the authenticity. These are the valid terms. They are the established diagnosis, but we are not able to diagnose. Forget about the treatment. And who is supposed to deal with these patients? So whatever concept we are having, that poke, inject, and forget, that has to be strongly rejected and strongly condemned. If you really want to know what is the chronic pain management, just forget about it. By far now, we all are aware that chronic pain, yes, it is a major problem. It is an existing disease. It is affecting almost everyone. Almost every fifth Indian is suffering from chronic pain. We have some figures where they are mentioning that almost 180 million Indians are suffering from arthritis. We have second highest number of patients who are suffering from chronic pain next to China. The incidence of the prevalence of chronic pain is almost 13%. That is, every 13 among 100 patients is having chronic pain. And the worst part is 95% of the patients who are having chronic pain, they are consuming NSAIDs. I'll just briefly tell you that chronic pain, almost 40 to 50%, or some part of chronic pain is always mixed. There are two types of pain. Chronic pain, nociceptive and neuropathic. Okay. Nociceptive pain, yes, it will respond to NSAIDs, but neuropathic pain, hardly it will respond. And whenever it comes to chronic pain, there will be mixed entity. So imagine if all the patients of chronic pain, they are consuming NSAIDs, means it is totally improper treatment. And just imagine 95% are consuming NSAIDs. God knows what is happening with their kidneys. So by far we are agree upon the statement that yes, chronic pain is a problem. Then who is supposed to deal with this problem? Who is supposed to treat this patient? The problem here is we are clear about the seriousness of chronic pain, but we are not clear about what exactly the pain is. What do we mean by pain, and what is the concept? What is our concept of pain? So let us see this IASP, that is International Association for the Study of Pain, has to say about the pain. It defines the pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I'll repeat it. It is an unpleasant sensory and emotional experience, sensory as well as emotional. It is associated with or resembling that it is associated with actual or potential tissue damage. Okay, definition, we have read it. We have understood that not only sensory, but also emotional component is there. But what is more important is ISP have added 6 keynotes regarding this concept of pain. As far as my whole presentation is concerned, what I feel is this particular slide is the most important, and it is the crux of my all presentation. If we are understanding, or more appropriately, if we perceive the concept of pain, then only we can think about its treatment. If we are able to perceive the definition of pain, then only we can think about its treatment. So this ISP have added 6 key points about the pain. That is, the pain is a personal experience. It is influenced by biological, psychological, and social factors. Not only biological, but also psychological and social factors. Okay. This is again very important point. Pain and nociception are different phenomena. Pain and nociception means pain is not only about nociception. There are other entities which are also there with pain. Okay. Through their life experiences, individuals learn the concept of pain. 4th point is very important. A person's report of an experience as pain should be respected. This is actually the take-home sentence. If a person is reporting of an experience as a pain, it should be respected. We cannot label it as a psychological patient. ऐसे ही बता रहा है, he is not suffering from pain. नाटक कर रहा है. We cannot use such words. A person's report of an experience as pain should be respected. Again, the 5th one, though adaptive, the pain affects adversely on function and social and psychological well-being. We'll try to understand this. The pain is adaptive, yes, means gradually patient will, the pain threshold will be increased, and as such nociception will be less. So it is called an adaptive word is used. It is adaptive, but it will affect adversely on function and social and psychological well-being. Means the function and social psychological complaints has to be dealt more prominently than the nociceptive complaint. And the last, this is also very important, inability to communicate does not negate the possibility of pain experience. Suppose somebody is not telling you that he or she is suffering from pain, it doesn't negate the possibility of pain experience. So this is all about the ISP has to say about the concept of pain, that it is sensory as well as emotional experience. The pain complained by a patient, we should respect it. Pain and nociception are different. Though adaptive, it will adversely affect the social as well as psychological well-being. And inability to communicate doesn't mean that patient is not having pain. So if at all we are clear about the concept of pain, or if you have pursued about the pain, then only we can think about its treatment, or we can think about the targets and what are the minimum targets. As we have seen, pain and nociception are different, or pain is not only about nociception. The nociception part, yes, you have to deal it, but simultaneously you are also supposed to look after the emotional as well as psychological well-being of a patient. Means your pain target has to be nociception, the emotional level as well as the social level. So if we have perceived the concept of pain, and if now we all are agree upon by the statement that only poke, inject and forget, it not only about the chronic pain management, what exactly it is? It includes the evaluation as well as diagnosis. Diagnosis is very important, followed by medication management, then targeted procedures if required, followed by physiotherapy, for settling the disability, if any, then lifestyle modification to avoid future complications, regular exercise, psychological support, yes, it is also very important, and sometimes specialist coordination if required. This will explain in toto about the present concept of pain management. Is it so difficult? Is it really difficult to handle this entity called as pain? Not at all. If we go back to our basics, and if we if we remember that if you really want to be a good clinician, what is minimum required? Or if you really want to diagnose a particular condition and to treat it, what is the minimum requirement? Is thorough history, appropriate examination, followed by relevant investigations, then appropriate diagnosis, and finally rational treatment depending upon the psychosocial conditions of the patient. That is the basic knowledge which we require to handle this patient with chronic pain. And lastly, I just want to conclude my presentation, and then I will hand over to Dr. Desharaj. I want to conclude this by this very famous quote by John Dryden. He was the first British poet laureate. What he has to say was, for all the happiness mankind can gain, is not in pleasure, but in rest from pain. So I hope that up till now we have understood, or we have discussed the concept of pain, what exactly it includes, and what we are thinking about pain management is not completely wrong, but it is a partial truth. Now, what is the complete truth about the pain management and what exactly is pain medicine? We will listen it from Dr. Desharaj. So I will request Dr. Desharaj to please start his presentation and to throw upon light about this concept of pain medicine. Thank you.
Thank you, Dr. Amul. That was a very brief this thing and a very elaborated talk.
Good evening. It was a very nice presentation regarding how exactly the thought about pain is circulated in the society, and we are trying to just show the actual reality, what is exactly the pain management is. So I'll, without wasting time, I will just share my screen.
Yes, it's visible. Just put it into presentation mode.
Yes. Can you see?
Yes, it's visible.
And my voice is audible?
Yes, audible. Very clear.
Yes, thank you. So I will little bit differently think about pain. Just recently we have seen from Dr. Amul what exactly the definition of pain, but I will narrate it in little bit different way. So I would like to say that we'll derive pain as an experience. So why? Because we can see we can see that a pain is merely a signal that is transmitting from the tissue of the injury to the brain. Yes, it is true about the acute pain, but it is not true about the chronic pain. Why? Because when it is an acute pain, there is only a signal that is perceived by the brain that there is something wrong with the tissue. But when it is about the chronic pain, there is an involvement of the multi-systems. Like there is involvement of cardiovascular system, there is a sympathetic surge, there is a psychological anxiety, agitation. So there is a multi-system involvement. So we can say that pain can be merely as a signal, can be viewed as merely as a signal that signifies something wrong somewhere in the body, unless it is attended to or perceived in a certain way. But when the system is involved, the limbic system plays a very important role in the modulation of that pain. So that is because the amount of pain experienced by a person is different for a subjective individuals. So it may be different for one person, or it may be different from other person. So the limbic system plays very important role in the experiencing or affective component of the pain. For example, I can show that in some cancer patient, it has been shown that if you do the frontal lobectomy, there is complete abolishment of the affective component of pain. So patient can perceive pain, but patient cannot react on that pain. So the affective component is also important to be handled as a pain physician. Now, one more thing we can see, if we view pain as a warning signal, so it is helpful because it is actually signifying there is something problematic to your body or some tissue is getting injured. So it is a survival response and it is a beneficial part of our life and modification of life. But if we consider pain as a threat, then the threat value of the stimulus is also important because we have to focus the attention on the threat value. For example, for a joke, I will tell one example. If some person slaps on a face and if some person or a friend slaps on a back as a hey, so there are two different kinds of threat values of that slap, even if it is of the same intensity. If person slaps on a face, people will become angry, and if we slap on a back, it will be a good gesture of a friendship. So the experience of that same slap of same intensity is different because it is perceived in a different way. So the threat value of that pain has to be taken into the account because the threat as the and one more example, if we do a pinprick to a person and if a patient is suffering from a major surgical injury, so the threat value of the surgical injury is obviously greater than that pinprick. So we have to keep more awareness on that surgical injury rather than the pinprick. So this awareness, it is dependent on the threat value, and that is that forms the pain belief that are called as organic pain beliefs. So what is important in maintaining that beliefs? One is a maintain sensitization. It is a little bit of difficult term of the pain is perpetuation because maintenance of pain beyond the time of healing. If there is some injury and the injury is healed, but still pain is there, that is because of that sensitization. What is it? It is unexplainable pain that occurs in absence of injury or a secondary or some secondary medical condition. So here what is occurring? Actually, there is a no threat value of some injury, but there is actually psychological threat value is increased. So there is a disproportion between the actual threat value and the psychological threat value. The patient is perceiving more and more pain despite of there is no any injury. So that is called as a psychological threat value, a psychological pain belief. So this same occurs in the fibromyalgia as we have shown or post-stroke pain syndrome. There in fibromyalgia, there is no actual pathology in the peripheral joints, but patients' complaints of the joint pain are all multiple pain symptoms. That is because of the threat value that is increased due to sensitization. So what exactly the central sensitization is? It is a little bit a difficult topic, but I will little bit just enumerate a focus on the important parts of the sensitization. It is because of the poor endogenous analgesia. As we are all anesthesiologists, we know about endogenous opioid system, that is enkephalin endorphins. So normally it is activated by the any injury response. But here what occurs? There is a decreased poor endogenous analgesia. So there is an increased pain stimulation. Second part, there is increased activation of the nociceptive facilitatory pathways. So there is more and more stimulation that will lead to the more and more pain generation. Even there is no stimulation. For example, we can see in burn patient, if a patient is removed from that burn stimulus, still the patient persists at burning sensation. That is because of the repeated firing of that burning signals to that brain, and that is called as a sensitization. So there was one study that was conducted regarding sensitization. The patients of knee osteoarthritis were studied and the functional MRI were done for the non-articular stimulation of that joint. That is, the joint were stimulated extra-articularly. The tibial painful sensation was given to that joint, and the responses were noted on the functional MRI. So let us see what it has shown. So they have shown that the patient who were sensitized to that knee osteoarthritic pain, they were more stimulated rather than the non-sensitized part, because their stimulation was a tibial actually, which is an extra-articular stimulation. There was no pathology on the tibia, but still the sensitized person were stimulated. Why? Because the area of the pain, because of the secondary hyperalgesia and sensitization, are more in the sensitized individual. So there is a more stimulation of the brain in sensitized person than non-sensitized person. And the control subject, there was no any stimulation because patient's pathology was normal. So here we can see the importance of sensitization. So if a patient is having chronic osteoarthritis for a long term and he is sensitized and he undergoes only total knee replacement, still some patient perceives about the pain because of post-care pain. That's called a post-care pain. Why? Because of this component is actually not handled during that pain management or during that treatment of that some disease or. So this has to be focused. So that ultimately lead to the development of chronic pain syndrome. So what is chronic pain syndrome? It is a phrase used to describe the constellation of problems often seen in persons dealing with the chronic pain. Frequent characteristics are high level of pain behavior. Patient may be agitated, patient may be repeatedly disturbing gait, turning the position, and elevated use of medical resources. Patient may take irrationally medical drugs, NSAIDs, all to relieve that component of pain. So this chronic pain syndrome, when the pain develops into the chronic pain syndrome, there should be some part of a study. Classical way of the pain management is not necessary over here, because if we do only injection and if we relieve the patient will not get treated. So to treat that patient, we have to diagnose the chronic pain syndrome state rather than to the pain state. So for that, there was an introduction of one model that is called as a biopsychosocial model of pain. So what is it? It includes the biological part, psychological part, and social part as well. So what biological part we know is a tissue injury, neurochemistry, there is a transmitters, there is transduction, transmission, physiology, genetics, all that we know. But rest 70% part in that part is not covered in the pain management normally. So in all the perspective of chronic pain, we have to consider these psychological factors, like a patient is feeling anxiety, anxious, agitated, angry, and all that. And the social affection part of that, because of the patient is psychologically disturbed, so it has an affective component on society, on the family, on all the workplace, and all that. So we have to consider all these things. So to study all these factors, there was an introduction of the subspecialty called as a pain medicine. So what exactly is pain medicine? Is pain medicine or algiatry? It is a discipline within the field of medicine that is concerned with the prevention of pain, evaluation, treatment, and rehabilitation of persons in a pain. So it was a definition given by the American Board of Pain Medicine. So we will see it one by one. So what exactly is prevention of chronic pain? So it is a knowledge about mechanism involved in development and the perpetuation of pain. So what is the development and perpetuation of pain? As we all know, some medical example I'll give. If a patient of acute herpes is getting treated with the physician, and he prescribes inadequately antiviral drugs, so the viral load remains in the ganglion, and after some years of his relief, patient may again come to him saying that there is a post-herpetic neuralgia. So why was the reason the post-herpetic neuralgia was developed? It was an inadequately antivirals were prescribed that had led to the accumulation of the virus in the ganglion, and that has maintained it to the chronic pain state. So if the physician would have been a knowledge about this pain mechanism, he would have treated it very aggressively and very adequately. So this is very important. Second, when we are dealing as an anesthesiologist in a OT or post-surgical team, the surgical pain management is also a very important part, because if you manage it adequately with the regional anesthesia, epidural, or whatever the sort of analgesia we are having, so that will lead to the prevention of that chronic pain state. Patient may not get into the chronic pain state, like in the amputation state. If a patient is adequately managed during the amputation, patient may not end up into the post phantom limb pain. So the adequate management during the part of anesthesia as acute pain services is also important in that perspective. So this means what is important here is to emphasis should be given on the prevention of sensitization. That is the most important part in the prevention of chronic pain. So when it next comes to the evaluation of pain. So while doing the evaluation, I have gone through one study. There was a one study where they studied what do the patients expect from their first visit to pain clinic. Some people have studied a lot of patients. What is expected when you visit your pain clinic? But the data was very surprising. They were 90% of the people were not expecting the pain relief, but they were expecting there should be someone to listen to their pain, or someone should understand their pain. So that has enlightened some part of my mind that if a patient comes to you, there should be some person to listen or some person to entertain that pain. You should not label it like, no, it's a psychological and you should go to somewhere. It's like we have given the block and now you should go to somewhere. It is not like that. We have to understand the part of the pain. We have to understand all the comorbidities associated with that pain. So the evaluation of the pain is different from the routine clinical evaluation. When you do in the medical practice, the evaluation consists of the only physical thing: history, clinical examination, investigation, and diagnosis and treatment. But here we have to consider it in the multi-dimensional way. So what are the multi-dimensional ways? One, when we have to think about the physical part of a pain, where is the pain actually generating, we have to diagnose that. We have to see the psychological aspect of the pain. We have to evaluate whether the patient is having some psychological symptoms like anxiety, depression, and all that. We have to see the social affective component of that pain. And one more thing, our respected Dr. Balaji sir is practicing palliative care. So I would like to enlighten one more thing. There are also component of the spiritual aspect of pain. So in patients with the cancer pain, there is a component of spiritual part that has also to be evaluated during our clinical examination. So the history routinely consists of the pain generator and all that. Clinical examination. Here is included one more thing, that is the disability and the psychological evaluation and the investigation. But even if we do the needed relevant investigations, most of the time in 50% of part, there may not be any diagnosis. Most of the people of the spine, they can show the multiple disc bulges, but the distribution of pain is in the some L4 distribution or some distribution. So which disc is exactly the pain generator? How will you label? Or you directly give the epidural steroid to all the levels of the roots? And it is not like that. So you have to diagnose the pain generator here. So there was one important modality that is exclusive for the pain physician, that is called as a diagnostic intervention. So diagnostic intervention it helps the pain physician to determine the anatomical origin of patient's pain, or tissue of origin of patient pain, or pain generator, we can say that. So not necessarily it should be like a nerve block and all that. There are the two types of diagnostic intervention. One is a relieving intervention, one is a provocative intervention. Where in relieving intervention, what we do, we inject the local anesthetic to a structure or a nerve. It may be a structure, it may be a nerve under ultrasound or fluoroscopy guidance. And if there is a relief more than 75%, it is diagnostic. Then we can go for the diagnostic strategies for that pain generator. Second is a provocative. What here is, we provoke the pain, we inject some part and something onto our diet, and we provoke that pain. So if we provoke the pain, that is a pain generator. One example of this is a provocative discography that is exclusively done by a pain physician. When there is a discogenic back pain and we have to identify exactly which disc is causing the pain, we inject the dye into the disc, and at that time we measure the pressure changes of the disc. At what pressure the pain is getting generated, at what pressure the pain is precipitated, or in the normal disc and the pathological disc. So according to this, we can diagnose the actual discogenic back pain. So this is also a part of a diagnostic intervention. But now we have diagnosed, but how to manage? So there are the management strategies. There are 2-3 management strategies I will discuss in further discussion. One is a multimodal management. So what is multimodal management? Multimodal, there is a concurrent use of separate therapeutic interventions. When there is a one discipline that like a pain physician is treating, but it treats the pain in a different modality way. So to target the different mechanisms of the pain. Suppose there is a peripheral pain generator, we can give the intervention. When there is a central sensitization, we can give the medication. So in both the aspects, we are treating the pain and with both the mechanisms. So there are 2 types of multimodality management. One is a pharmacological, one is a interventional. Analgesic and co-analgesic. Co-analgesic acts on the pain modulation. So an interventional we all know. So I will not go into the detail of that interventional part. So the treatment focus should be on the central sensitization and the peripheral sensitization. But before that, we have to diagnose which is the actual major component of that chronic pain, whether it is a peripheral mechanism or whether it is central. So according to that, we have to treat that chronic pain. So this is the pain pathway where a lot of the drugs intervention where it acts as the transduction, transmission, then pain perception level and the pain modulation. So there are, by this way we all treat that chronic pain. But is it adequate? Is it adequate to treat in the multimodality way? No. Actually, why? Because there is no any handling of the psychological component. So there is a need of multidisciplinary approach. Why? Because chronic pain comes with all these reduced activity, sleep disturbances, then the physical deconditioning, then the feelings. They have a lot of psychological component as well as a physical component. There is a muscle wasting and all that. So who will treat all this part? So during the pain management, we have to treat the pain as a whole. It should not be treated like a single entity. So the functional disability and emotional distress has to be also taken into the account while treating the chronic pain. So there is the introduction of multidisciplinary approach. So what is multidisciplinary approach? It is provided by the practitioners of different disciplines. Modalities in multimodality, we have seen there was a various modalities under single discipline. But here we are using the multiple disciplines to treat a particular chronic pain. But multidisciplinary pain management has addresses physical, psychological, social, and occupational parts. There may be indulgement of that surgeon as well. So while treating the chronic pain, you can add the surgeon also, you can add the neurosurgeon also as a team member to treat that chronic pain, because we have to treat patient as a whole. We don't have to treat a particular part of a pain. We have to treat that disease actually. So multidisciplinary approach, pain medicine consultant handles the molecular part of the pain, like with the medical management, with the interventional part, and the sensitization management and all that. In the psychotherapy, we can see that there is a one structured format called as cognitive behavioral therapy, which will handle the behavioral and cognitive affective component of the pain. So that is also necessary, because pain also comes with the psychological part. So we have to treat in that way as well. And third, the functional disability is covered with the physical therapy persons. So collaborative efforts of this all is necessary to treat the chronic pain syndrome condition. So, but what is occurring here in the multidisciplinary approach? All the professionals were working separately. If I treat a chronic pain, I'll refer to the physiotherapist. He will treat in his way. He will refer to psychotherapist. He will treat in his way. But that is not actually a good thing, because when there is no communication between all the disciplines, the patient as a whole cannot get treated, because I have my own ideology of treatment. Physiotherapist may have his own ideology of treatment, and psychotherapist will treat in something in a different way. So there should be some part of the common communication. So there is an introduction of one more part called as an interdisciplinary approach. So what is interdisciplinary approach? It is a treatment provided by a multidisciplinary team, but it is a collaborative assessment and treatment using a shared goals. We have a shared goal of treating the pain. So according to that, all the people here, the pain physician acts as a team leader, and he directs all these specialties to treat in a particular way. So he directs physiotherapists, he directs psychotherapists, he directs occupational therapists and all that. So according to this, we have to treat pain as a single whole syndromic entity. So this will be the appropriate way of management. Here, all working closely together with team meetings, face-to-face or online, whatever. There may be the therapeutic aim or plan for the treatment of review. But so in this way, we have to treat the interdisciplinary management of a pain as a whole. But how will you confirm that whether you have treated that patient actually, whether the patient is actually getting treated or not? So how will you define your success of pain management? So there should be a clear and focused goal, which is critical for the success in the interdisciplinary management of the pain. So what are the goals? One is to reduce pain, that will be handled by the pain physician. One is to increase the activity, that also be managed collaboratively with the physical therapist. There is the resolvement of the disability that claims and the return to the patients to the work, that will improve his social impact or work balance, and the patient may improve creativity or produce productivity with this increasing his work. Then the reduce opioid medication, that is a very important part. Recently we are dealing with the high opioid epidemic. So this is also taken into account, that opioid should not be used for the long period. So reduce opioid medication is also more important part in the interdisciplinary management. Reduce emotional distress, that will be handled by psychological person. Reduce depression, anxiety. So patient may feel better. Patient may change some ways of thinking. Patient in cognitive behavioral therapy, the patient may think in a different perspective, in a different way to that pain, so that they can improve their mobility and all that. And at the end, to decrease the use of medical resources. All the medical resources are irrational. They are taking the medication. That has to be abolished. That is very important. So the interdisciplinary management of pain is very important task. That is very important task which is landing up into the in front of the medical fraternity. So at the end, I would like to say, there should not be a poke, inject, and focus attitude of pain management, as previously Dr. Amul has described. It is very wrong concept of a pain management. Pain should be carefully assessed, evaluated, and treated as a whole biopsychosocial model of pain. And at the end, interdisciplinary approach is the best way to manage the patient with a chronic pain. So it is a teamwork always, and the teamwork we no need to say to the anesthesiologist what is important of team. So teamwork is very important here. So collaborate. So the patient should be treated as a patient. It should not be treated as a particular pathological tissue. So this is a way to treat the pain. And thank you very much, Aurangabad Anesthesiology Association Secretary Dr. Sujata Madam, President Dr. Sangeeta Madam, for inviting us for such a beautiful talk and the awareness part of the pain medicine. And I will conclude here my presentation. Thank you very much.
Thank you, Dr. Jeshtraj and Dr. Amul. That was really a very highlighting points you have thrown on the pain management. I would like to request our moderators to please add their inputs. Dr. Arvind Rajguru sir, Dr. Pramod sir, Dr. Prasad Deshpande sir.
Thank you, Amol. Thank you, Jeshtraj. First of all, I would like to congratulate both of you.
Thank you, sir.
You are exactly thinking like me when I was thinking 10 years back. I really appreciate your efforts.
But now, sir, we are together to create a change.
Yeah, definitely. I am there. No one was there to guide me, but I assure you, I am there.
Yes, sir. Thank you, sir.
The first and foremost thing you are explained that the pain physicians, they are not the technicians.
Yes.
Yes.
Someone is asking you to put the epidural steroid and you are putting it. That is not our job.
Yes.
You must take history, evaluate the patients in our way. Because the vision of the other branches and pain physician, they are definitely different. Let me share some of my experiences. Out of 100 experiences I have got in my 10 years practice. The first experience was a patient from Manmad who was a truck driver having history of headache. A general practitioner gave him some NSAIDs, treated him from 3 to 4 months. Unfortunately, patient doesn't have pain relief when he was off the drugs. Then he referred patient to the MD medicine person who diagnosed he's having migraine or migraine-like symptoms, and he treated that patient like that. But unfortunately, again, almost 1 year has passed. The patient was not getting relief, and then he sent patient to the DM neurologist. Then DM neurologist conducted MRI, all this very costly investigations, everything. Then he again kept the medicine for the migraine and asked him to continue the medicine. Again, 2 years passed, but the patient doesn't get relief. Finally, that neurologist get irritated and asked him to go to the psychiatrist. The patient, he was in need, he went to the psychiatrist, he received treatment, he was bus driver and truck driver, and all the medicine he was receiving, he was not able to drive his truck, and ultimately his family was suffering because all the medicine for psychiatric use, they make patient drowsy. No, I don't know from where he get my clinic's address. He came to me and the road was clear for me. I was knowing that I don't have to go with this way. So I choose only the way which was remaining. So I took his history, I examined him, and to my surprise, I found that he was suffering from the cervicogenic headache. What Amol has mentioned is one of the slides. Then I directly go for the interventions because already patient was suffering from 3 to 4 years. He was not getting relief. He was having bilateral pain. So in the neck, usually I don't prefer to go for the bilateral in the same setting. And to my surprise, he was having 70 to 80% relief on one side, but the pain on the other side was also reduced. He was very happy. And after 1.5 months, he came to me to get these interventions, that is facetal joint block, that is median branch block. It is simple procedure, daycare procedures, and he was absolutely pain-free after the second procedures. That was the magic of pain management. But I again advise to young physicians or young pain physicians or who is practicing in the pain, that don't be a technicians. Second most important thing that Jesters has mentioned about the sensitizations. Again, I would like to mention one of my experience. What sensitization exactly is? He mentioned in his one of the slide that if we don't take proper precautions of the pain in the acute situations, patient may land in the peripheral and central sensitization, and patient may have long-term effects. But this is well explained in phantom pain. But there is one condition. I have faced two patients. One patient was having, I think Balaji was knowing about this case. One patient was a crush injury, thigh. The patient was admitted with Dr. Bemde sir. And the regional anesthesia there, Dr. Bemde madam was giving the regional anesthesia most of the cases in spinal anesthesia. So second or third time when debride was done by the Dr. Bemde sir, third time she introduced spinal anesthesia. And as the spinal anesthesia was given, the patient was shouting very severe pain in the crush injury. He was shouting like anything. There is severe pain, severe pain. So Dr. Bemde madam could not make out what was happening to the patient. And the team decided that the anesthesia could not be proper. So we will postpone the case and we will plan the case in the second time. But the second time, then at that time I was in the ozone group. And second time the case was shifted to our group. So I was the anesthesiologist and they told me, this happens. Yesterday she had given the anesthesia and patient was shouting like anything. Isko effect nahi aata. So I was a pain physician. So I thought in that directions. So let us see. Spinal dete dekhte kya hota hai. So I gave spinal anesthesia and the same scenario starts. As the patient was having dense anesthesia and patient was shouting, having severe pain. Patient was not able to move the limb. On the other side, there was complete anesthesia. The level was almost T10, T8. But patient was shouting like anything. Now what is this? How to explain this? This is called as the central sensitization. So the simple method, simple treatment for this, just give midazolam and injection ketamine. Ketamine is very important in the such scenarios. So that is which blocker? Gestrage?
NMDA, sir.
Yes. So it blocks the receptors and that gives excellent relief. So this was my second case. Anyway, good to have see this all discussions on pain management. And now I would like to ask Prabhu to share some of his experiences. Yes, Amul.
Yes, sir. I just want you to have some special announcement regarding our ISSP city plan.
Okay. I will do that, but let Pramod and Prasad share their experience.
Yeah. I just want to share my experience because Padu very well explained about the missing link between all this specialty and what is the necessity of this specialty particularly.
Yes, sir.
So one patient was referred to patient for the limb pain and he diagnosed as a TO, Burgess disease. So while evaluating, he also evaluated there was some STD changes and some chest pain. So he posted that patient for the angiography and peripheral angiography and coronary angiography. So patient had both disease, peripheral vascular disease and also TVD, not the single vessel disease. But patient's main complaint was the lower limb pain and having a multiple ulcers of the lower limb. So in that, physician has given medical line of management, but patient could not be relieved. Physician referred to the cardiac surgeon, but the cardiac surgery is the peripheral vascular surgery is not possible because patient was having the coronary artery disease, and the stent cannot be put because it was a TVD. So the cardiologist, surgeons, and the physician could not help this patient. Now what to do? So they referred to me. So I have stopped clopidogrel, continued the ecosprin, and given the lumbar sympathetic block. the chemical sympathetic nerve. So with that chemical sympathetic nerve, patient not only the pain relieved, but almost 95% the ulcer also has been reduced. It was just up to the 2 only. So the patient in that scene, patient's pain was relieved almost more than 90-95%, and then patient posted for the CABG. So the role of interventional pain management is definitely there. If all the 3 super specialists could not able to handle that patient, so with that I want to tell to the audience that there is definitely a great space for this pain physician and the specialty. And as Jestra said, this interdisciplinary action is very much needed. So I congratulate both of you, because you have the person who has started not only not only to bridge the missing link, but also by developing the clinics, the interdisciplinary approach, we have made it a path to our needy patients.
Thank you, sir. Thank you, sir.
Prasad sir, can you add your inputs, please?
Yeah. Hello. Am I audible?
Yeah. Yes, sir.
Yeah. First of all, again, I will.
Prasad, on your video.
Oh, sorry.
No, very clear.
Yeah. I would like to congratulate both Amul and Jastraj for excellent presentations. And as both Arvind and Pramod have said, it's actually a very good work they have started by trying to bridge the gap in between everybody. Regarding the experiences, I would also like to say that, as Pramod has said, this area of vascular disorders is also very important, and very commonly patients are presenting to us, which can be very beneficial to patients. Like as Pramod has said, lumbar sympathectomy. Similarly, stellate ganglion for upper limb also is very useful. And these things are not very commonly known to other people. So this should also be highlighted in because most of the time, whenever pain practice is considered, patients or doctors, they think that lumbar disc, that is the area where pain physician is involved. Or at the most, they say trigeminal neuralgia. Apart from that, kuch nahi rehta usme. So these are things also we should highlight to other doctors, especially. Patients will come later. We have to educate doctors about that also. So anyway, thanks for an excellent presentation, and thanks to AA also for organizing such an event.
Thank you, Prasad. Thank you, Dr. Arvind. Thank you, Dr. Pramod, and thank you, Dr. Prasad, for being moderator for such a nice session. Now, Sujata.
Madam, I just wanted to ask one more question to all our pain expertise over here. How to deal with minor aches and pains which are in the day-to-day life. Mostly the back pain, lower back pain, or the small joint pain, and of the post-COVID, the regular basisly on your relatives, your colleagues, or some or the other person is saying you there is some joint pain, either minor or major joint pain. So can you correlate this to the post-COVID, or how to go through for this to manage such issues?
So for your muscular pain and all this day-to-day pain, what you are told, I think postural correction is the most important thing.
Okay.
While we are working, while we are sitting, while we are driving the car, while we are driving the scooter, all these very, very, very minute things are there. There are 2 things: what happens and why happens.
That's it.
I always explain to my patients ki काय झालंय आणि कशामुळे झालंय. Muscular pain is there. Both questions are always there. So I have to explain the patients. Only काय झालंय म्हटल्यावर आपण ट्रीटमेंट देतो, मसल रिलॅक्सेशन, पेन किलर, टेम्पररी रिलीफ होऊन जात. पण त्यांच्या पोस्चरल करेक्शन जर प्रॉपर केल्या गेल्या नाहीत तर हा पेन रिकर होत राहतो. हे पेशंट मग एक डॉक्टर, दुसरा डॉक्टर, तिसरा डॉक्टर फिरत राहतो. हे याच्यासाठी आहे. आणि दुसरं नाही म्हटलं तरी हे जे multivitamins किंवा minerals, they have a good role in day-to-day manner. Pain, cough pain, this simple things are there.
Right.
Amul, you can add something, or just as you want to add something.
Sir, you told the change in ergonomics. Yes, I do agree with you. It is very important. But I just want to mention one point. As Madam has told, if there are minor aches and pains, if they are of acute onset, and if they are responding, and if you are feeling well, it's okay. You can not exactly ignore, but if they are responding and if you don't have any other episodes of the similar pain, okay, you can ignore. But if you are having repeated experiences of the same pain, it needs evaluation. That's all I want to say. It needs an evaluation, and I would say that it needs an evaluation by a pain physician.
I would like to add one more thing.
Yeah.
Recently, I have seen you have mentioned about post-COVID pain syndrome.
Yes.
Recently, I have seen a lot of patients of the inflammatory arthropathy in the post-viral state, and multiple people. I don't have to name any person, but multiple people are prescribing irrational medication like hydroxychloroquine, then the steroids, and all that for the post-COVID or post-viral inflammatory arthropathy. So that is actually not the way to treat that post-COVID or post-viral arthropathy. Inflammatory part in the post-viral arthropathy is going to occur for some period of time. So we have to give time to the patient. We have to increase the activity. We have to mobilize that patient, because the inflammation is going to set when there is immobility. And with the pain, the patient is not going to mobilize that joint. So increasing the mobility, physiotherapy, and a simple analgesic like a paracetamol will help for the that inflammatory arthropathy. No need to go for that disease modifying agent like a hydroxychloroquine and that all the steroids, which are obviously should not be prescribed in the irrational way. Thank you.
But there is a vicious cycle. See, with some medication you get the relief and then you work. But after repeated attacks of the joint pains and all those things, the medicines also act less, and ultimately the patient land in decrease in the mobilization, and as you said, so all sorts of things. That sets in again a vicious cycle.
Oh, in that you have to investigate the patient properly. You have to do ESR, CRP, some antibody testing. It is needed because it is seen post chikungunya and all. This patient had landed in the rheumatoid arthritis.
Yes.
There is a molecular mimicry where there is a common antibody which are sharing the same with the synovial fluid. So in that scenario, this patient may land in the rheumatoid arthritis like arthritis. In that scenario, you have to do the investigations properly. Okay. It is not that just as I have said, it is good suggestion in acute cases. But if the arthritis and all these things last for more than 3 months, then you have to think seriously about these patients. And this patient may need hydroxychloroquine or steroids for short periods. Definitely, they are modifying the disease modifying agents and may give a good relief to the patients.
One more question. How do you keep the follow-up of the patient? Because what I find a tedious job in the pain management or pain physician is the follow-up of the patient. Many a time you lose the follow-up of the patient. You give the blocks or somewhat like that expertise, and the patient is already wandering from one place to another place and he doesn't get relief, and we lose the contact. So how you maintain the follow-up part?
So patient, they do their follow-up regularly. It's my experience.
Okay.
I don't have that experience, fortunately, up till now. Don't know now, just Rajana. Amul is there. I don't know now. My patients will go to their famous.
Actually, I want to have one comment on this. As Sir told, the patient will definitely come. But I can point out the reason why patient will definitely come for follow-up is only because we are listening to the patient. All these patients with chronic pain, there is no one to listen to the patient. Yes. Nobody is even agreeing upon their complaints. As I have told on my presentation, that even patient is not having complaint of pain, still that patient can have pain. Yes. And whatever my boss, my teacher has told to me, Dr. Gautam Das sir, whatever I am is only because of him. He has told me that minimum you should spend 20 minutes with the patient. And let me tell you all, we are following that principle.
Yes.
We will listen to everything of the patient, and not only the nociceptive complaints, but it includes emotional as well as psychological complaints. And I don't need to tell you that if you are touching your patient emotionally, that patient will definitely.
I agree, Amul, with you. One patient definitely took more than 20 minutes.
Yes, sir.
Proper evaluation and all this.
I would like to add one more thing. I said in evaluation part, same thing told by the Amul. Should be establishment of doctor-patient relationship. The patient will tell you the history when you will interact with them with empathetically, not with sympathy. There should be empathy, and that empathy is very much important to establish that doctor-patient relationship. And that empathy will lead to the follow-up. And patient will come to you again when you will evaluate, when you will properly diagnose, and most important thing, when you will listen to that patient. That is important part.
That's right. Just on friendly basis, can I ask what difficulty you face while starting your pain clinic, and how you get your response from the colleagues, you being so MD anesthesiologist, going in such a direction?
A lot of difficulties are there definitely while starting some new venture.
Yes.
It is totally different branch than anesthesia. The first thing, you have to sit in the chair. You have to take the history.
And we are always roaming with the bag here and there.
Prescribing different drugs.
Yes.
Initially, it was just some NSAIDs and all these things. So this is having some learning curve definitely. And over a time period, as Amol has said in his first slides, that patients are great teachers. Definitely. My patients have taught me a lot of things. How to talk, how to tell, how to take history, how to prescribe, everything patients taught me, definitely. Now, shall I announce about our...
Please go ahead.
We are eager to hear that.
It's an opportunity.
Yes.
That in recent soon, our pain physician in Aurangabad are going to launch our new city branch, that is Aurangabad Pain Society. So I got an opportunity to elect as the first president of this society. Amul, thank you.
You are our backbone, sir.
Amul is the secretary, and I assure you, she is very dynamic secretary. I'm very happy to having such a secretary.
So we got two good news.
Ma'am, there are many news.
Good contribution, though he is a treasurer, but he's advising all the things. He is taking his active part in this. And Pramod is giving his all experience. He was having secretary of and his all experience he shared with us. Yes. And all this, we are all this doing very good. Bhale sir, then Supriya Kulkarni ma'am, all these are the faculties of our society. And in recent soon, almost all the formalities are completed now. And you will get the news in recent days. Amul will tell better way than me.
Actually,
Amul, can you elaborate something?
Yeah. Actually, one very special thing I want to tell about our very own Aurangabad Pain Society. And I'm very happy to share with our parent branch, that is ISA Anesthesiology, that recently me and yesterday we have been to Bhubaneswar for a national conference. We were there for the ultrasound workshop as faculty. So in the GBM, actually Aurangabad Pain Society, means the ISSP, the Indian Society for the Study of Pain, its city branch Aurangabad. Our branch is the only branch during last 3 years to establish itself during this COVID era. So it was specially appreciated that in spite of COVID, where people have left the pain practice, these people have come up and they have tried to found the brand. So it was very much appreciated. Means we all were also not in that way to accept that warm wishes, but they have really appreciated that you are doing very good job, and they have assured us that they are there for full support. So I want to thanks again our future, or for that matter present president Rajendra sir, for standing us as a backbone. The senior members, Pramod sir, who is there, who has taught us what you can say, the ABCD, how to start, how to form a society. We were like totally blank people. We don't know anything about it. But sir has guided us very well. Then Bhale sir, Supriya madam. And one more thing, one more very special person I want to tell, Dr. Sadhna Kulkarni madam. She was there since beginning, and she has encouraged us for everything, everything, right from entering into the pain up till the establishment of a branch. And she has assured us that she will be mentor of our society also. And she's the first and I think the most senior member from this ISSP from Aurangabad.
Yes.
So all in all, we are trying to establish pain medicine as a subspecialty of anesthesia, and as present in future also, we hope full support from the AAA, that is ISSP Aurangabad, and we hope that in coordination we will take more and more activities, and we will increase the participation.
Exactly.
And most importantly, as sir has told, that we being a young person, we want to include more and more young physicians to divert themselves in this field, because opportunity is numerous. Opportunity is very great in this field. So if newcomer is coming, of course he is energetic, and he is like, he will be more of interested, because let me tell you, we have to stop the practice of anesthesia if you dedicatedly want to practice a pain. This, my statement may be objectionable, but literally we have to stop. Then only it is logical. If we are focusing only on a particular branch, then only it will grow. And we want anesthesiologists like us only, who are dedicatedly trying to work in field of medicine. Then only it can grow. So I want to take this opportunity. I want to use this platform to request, and to even the senior people can also come. It is not like that only the newcomers. Even the people, those who want to really put forth their skills, their diagnostic skills, their management skills, they can also come forward. And it is not difficult. Sunata madam, you have asked about the difficulties. I want to tell the easiness. If you have a strong team, definitely you can come up. But the only thing matter is your attitude. If you have that particular attitude, nobody will going to stop you from becoming a good pain physician. So if you have attitude, no difficulty. I think Jessraj will agree with me that up till now there is no difficulty word has come across with us. No, nothing was difficult for us. Means difficulties, hurdles were there, but our focus was not on difficulties. We were just focusing on how to solve those difficulties. So again, as sir has told, soon we are going to have an official announcement regarding ISSP, but almost every work has almost done, and we are in a final stage. And in future, we will, as I have requested, in future, please keep your support to conduct a good activity in coordination. Thank you.
Thank you, Amul. Thank you, respected moderators, Dr. Rajguru sir, or also the president of Aurangabad Pain Association, Dr. Pramod Apsingekar sir, Dr. Prasad sir, and all the delegates who have joined today. I think Dr. Surekha Chauhan madam, the associate professor from Pune, she had also joined.
She is my teacher, madam.
Okay.
She is especially there for me.
Yeah, she was throughout there for the sessions. Yes. Even Dr. Sameer Sohani, he's a treasurer of Maharashtra State Chapter. He had joined. Naik madam, madam is there, I think. So it was so nice to see Naik madam as well on the screen. I really congratulate.
If Naik madam can comment something about it, because
yes, Naik madam, can you? Would you like to add something? Is she there?
I think she left.
I think just now she left.
Okay.
Yeah. So all the best.
So I congratulate Pain Association as our branch.
Yes,
as our sister, or rather our brother branch.
No, as our sub branch. Because parent branch is ISA.
Of course, I have used the word parent branch, madam. Yes, parent branch. We all are.
I congratulate first President Dr. Arvind and Dr. Amul as a secretary.
Thank you, ma'am.
Congratulations, and I'm very happy to hear this news. So that we will be conducting a conference, right?
Yes.
And it's going to be a national one.
Not exactly national one. It will be a CME kind of a thing. National conference will be in Pune, madam. So we'll be helping over there.
Yeah, and team AA will be behind you for any help.
Yes, ma'am. Thank you. Thanks a lot.
Many congratulations, Jeshtraj. Many congratulations, Amol. Thank you. Thank you, our moderators. Thank you all. Have a nice good night.
We'll have a good weekend. Everyone.
A moment, madam. A moment, please.
Pardon?
Hello. I just want to share one more news.
Yeah.
As I have just told that we need more and more people to enter into this field of pain medicine. But what exactly happening in Maharashtra? There is no institute nearby to learn the basic about the pain management. Yes, even we have gone to Kolkata, and frankly, the courses which are available in the nearby in our state, they are not exactly oriented to the what exactly is the concept of pain management. So what we are trying to do is now, because we are very well equipped with the ultrasound machine, the radio frequency machine, as well as the fluoroscopy machine and the necessary setup, we are going to launch the basic course in interventional pain management, where we'll be having, it will be a fully offline course, where we'll be having a hands-on practice of interventions on mannequin. There'll be didactic lectures, the MSK ultrasound demonstrations were on volunteers, the fluoroscopy guided interventions, and mainly the focus will be fundamentals of pain medicine. And what is our idea is, it will be a very brief course which can be done by anyone. Why? Is just to know their own interest, where they are really interested in this management or not. Because what matters is your interest. And if they are really interested, then they can go for the higher courses which are available at higher center or even abroad. So by doing this, we just want to segregate, and we just want to give a platform where people can, or where students, or for that matter practitioners, can know their interest, that where they are really interested in this field of pain medicine. So I request those who are willing, please contact either me or Disharaj for the further details. Thank you.
Definitely, Amol. You can post this slide on our ISA humor as well, so that people can easily approach you.
Yes, even young or anyone who is interested, they can join.
Beneficial. And once again, many congratulations for one more venture for Panacea, Pain Panacea.
Thank you, madam. Thank you.
Yes. Congratulations. Good night.
Thank
you.
Thank you.
Thank you. Thank you, Arvind.
Thank you. Thank you.
Thank you. I will end the meeting.
Thank you.